Hi, so we are going to continue to talk about pain and pain relief. Okay? And again, what is pain? It's that physical, it's the chemical, it's the mechanical, it's the emotional component of pain. And so, modalities and therapeutic exercise go hands in hand on we are really trying to control pain. Okay? And there's a lot of things that again are occurring in that chemical reaction of pain. Okay? We have superficial and we have deep pain. But again, you need to know the anatomy of both the skin, the different pressure components, the different mechanoreceptors and proprioceptors, okay? In order to know what is being released, what is being damaged in the healing process. Okay? So we have all these different levels of pain. So, what is your Golgi tendon organ? What is your Ruffini ending? Right? Where are they found? Where are these nociceptors ones as well? And we have all these different pain rating scales that are related to pain. But that physical exam is going to be so key and asking those questions. Not just what type of pain, but the mechanism of injury, knowing the healing process. Where are they in that? And then we're going to talk about how are we going to deal with our pain a little bit later on. But I really want you to know that bisection. Right? So pain. Okay? We have the transmission of pain. Okay? And we can use things like cold, heat, light, sound to reduce the transmission of the perception of pain, as well as the chemical changes that are occurring. Okay? So a cold application is going to change the transmission of pain signals different than heat would. Same with electric stim. Right? And this table I think is really important because it tells you about the superficial and deep. So our superficial are our Meissner couples, Pacinian, Merkel's disc, Griffey endings. We have hot and cold receptors. And anytime you have a nerve ending that's free, think about like an exposed nerve ending on your tooth, it's going to cause pain both superficially and deep. We have our proprioceptors, which is going to be our Pacinian corpuscles, Griffey ending, Golgi tendon organs, which are also going to cause pain changes as well. So touch, vibration, temperature, proprioceptions all provide information to the central nervous system about pain. Okay? So knowing the differences and where they're located and what they do is really important as well. So mechanical receptors respond to stroking, touch, and pressure. Okay? Some adapt quicker than others. Then we have the hair follicle receptors and Meissner corpuscles and Pacinian corpuscles, and they are all touch receptors. And we have the Merkel cell endings and Ruffini endings, which are pressure and stretch of the skin, and they adapt much slower. Okay? And so that's a repetitive stimuli. We have our hot and cold receptors. Okay? They adapt, but they also, they adapt to the surrounding around us, but then when we can't handle that overload, it's going to cause pain. Okay? And that goes through a different receptors. Then we have these deep ones. Okay? They're really complex as well. Okay? They give information to the central nervous system about pressure, okay, tension, and pain. So your ligaments, okay, and other deep tissues are supplied by mechanoreceptors and nociceptors. We also have joint receptors in the Ruffini endings. Okay? And again, Pacinian corpuscles are also a low threshold and they adapt. Okay? We also have the Golgi-like receptors responding to compressive forces. Okay? We also have fascial pain. Fascia is kind of that outside webbing of the tissue that holds the body together. Okay? And again, within that fascia, we still don't understand the pain receptors that are there. But we also know we have muscle receptors, such as the muscle spindles, and they respond to change of length. Okay? So I mentioned before the different types of tracts that are out there. Okay? Spinal thalamic tract is one that I mentioned. Okay? But let's talk about the neocortical tract. Okay? acute pain is very rapid. And again, it goes through that 3-order neuron sequence that I spoke about in the first lecture. Okay? And so you have that nociceptor, okay, in that tissue, and it is going to respond to pain. The information travels up the spinal cord through the sensory nerve, also called the first order neuron. Okay? And then all of that information, okay, goes to the cell bodies, dorsal root ganglion, synapse at the spinal cord of the dorsal horn, and then we go to the second order neuron. And it crosses over to the opposite side of the spinal cord. Okay? That information goes up to the thalamus, where touch, vibration, temperature, proprioception, pain goes up the second order neuron to the brain. Okay? And again, the second order neuron carries information about multiple sensations. Okay? And then that third order neuron is that neocortical system. So it goes 1, 2, 3, those 3-order neurons. Now, I want to mention, I talked about the A delta and the C fibers. In that second order neuron, there are T cells. Think of T transmission when it goes up the spinal cord. It transmits up the thalamus. T cells are given to this neuron. And what does it give? T. Temperature, touch. Okay? Temperature and touch are really important, and they go up that second order neuron to the thalamus, to that third order neuron. We have this paleocortical tract. Okay? Well, first of all, Malzahn and Wall, they came up with a pain control theory that, it's kind of a gate controlling that opens and closes the gate to pain. So again, Wall and Malzahn are our big people. Here we have our paleocortical tract. Okay? It's considered our second pain, affective and motivational right here. Okay? So it connects all these different parts of the brain, okay? And what it's this describes the brain as the central command center, where you have lots of information which we know coming in at the same time. So it always begins at a receptor and it goes all the way up. So in this neocortical pathway, it begins with that C fiber going up to the T fiber, second order neuron, okay? Slow and low. We are also going to have that affective component, okay? And we have a memory component of it. So I want you to kind of remember those different components of spinal cord, then the different tracts that go up, okay? Here's our paleospinal tract, okay? All of this combined is the neocortical tract, okay? And we're going up to the brain, and then we're going to disperse out to the different parts of the brain. I gave you this before in a different table in the first lecture. Again, our A beta, our A delta, and our C fibers. Knowing the difference. You don't need to know the exact numbers for size, but you should know which one's bigger and which ones are not, which ones are myelinated, unmyelinated, and what do they transmit. Fast or slow. So I'll go back a little bit, okay? Again, so that's an afferent pathway. Real quick. A beta fibers, okay? They start in the hair follicles, Pacinian corpuscles, minor corpuscles, Ruffinian endings. Okay, they give you information, touch, vibration, sensation. They're large. Okay, fast conducting nerves. They have a low threshold because it's myelinated and fast. They have a low threshold, so they are easily stimulated. Okay, but they also accommodate and they conform to the stimulus pretty quickly as well. Okay. Then we have our A delta fibers. Okay, they transmit information from warm to cold receptors, some hair receptors, chemical receptors, mechanoreceptors, heat and cold sensitive transmission as well. These give you that painful stimulus, like when you get pinched, pricked, crushed. Okay, They're myelinated, but they're smaller. So they go a little bit slower, and it takes more sensory information for you to be able to say, I'm in pain, rather than touch. Okay? And then we have our C fibers, the smallest, peripheral, associated with pain. They're unmyelinated. Okay? They also have some other fibers in it. They're deep receptors. Okay? Few are thermo. Okay? But most are mechanoreceptors. They're the slowest, and they need the greatest stimulus in order to get pain to occur. Okay? So we have that whole ascending pathway. Now we have that descending pathway. Okay? So we go up the afferent tract, okay? And then it needs to come back down. So we have what's called this gray. In the paleocortical tract, okay, in the ascending pathway, some of the second order neurons end at the PAG, periaqueductal gray formation. Basically, that's what happens in the brainstem, okay? So the pain stimulus causes certain neurotransmitters to activate in the brain and others do not, okay? We have this thing called the ralphonucleus, okay? And it really controls our arousal in the brain, okay? The PAGs in this reticular formation and the ralphonucleus have the potential to affect, some parts of pain through the descending mechanisms, okay? So it's like an impulse that keeps on getting sent. It's where pain is acknowledged consciously. So when this area, the PAG, is activated, okay, a network of initiations can calm the person and help filter out some of the pain signals. Okay, you also have the pituitary gland there that can also either increase or decrease. Okay, and medications and modalities and stress relief can also decrease the descending pathway in this diffuse network. Okay, so think about, you have the hypothalamus, pituitary, and the ralphonucleus controlling subconscious factors. So if you can control your respiration rate and heart rate and attention, okay, sometimes you can decrease the amount of painful stimulus going into that cognitive area of the brain and decrease the perception of pain. So using those external factors are also, is in essence, stimulating parts of that brain, okay? When we have what's called that wind up, okay, is when, a painful stimulus can spiral out of control because the pain is exceeding the benefit of the part that's going into the brain. You have excitatory parts of the brain, which is now winding things up and getting more of that substance P with a release of the excitatory neurons, excitatory hormones, okay, amino acids, glutamines, all of these, and it's going to change your response in the second order neuron. And so you're going to have more pain receptions. So we're going to try to decrease this wind up component of it. Okay. So we have these transmissions that occur, and these occur in the synapses. Okay. So facilitatory depolarization. These are really important, okay? Because, again, we are all chemicals. Acetylcholine and glutamine are important facilitator transmitters, okay? You have acetylcholine, and it's involved in the transmission of signals, okay, for the parasympathetic and sympathetic nervous system. Glutamines, okay, they're part of the excitatory activity of the central nervous system, okay? So glutamine is part of a transmitter of the pain signals. We also have substance P, which transmits pain signals to the dorsal horn. Okay. We also, so those are the facilitators. You have inhibitories that try to block it as well. Glycine and GABAs, okay, they're inhibitory neurotransmitters. Glycine, okay, is predominantly in the spinal cord, where GABA is found in the spinal cord and the brain. Okay. So these are really important when we're dealing with chemicals, like any type of pain medications, okay, such as opioids, which we mentioned before. Okay? Enkephalins, you might have heard that word, okay, they counteract the effects of substance P. So substance horn promotes pain signals, whereas enkephalins try to block it. So we mentioned chronic pain, and chronic pain, it could be chronic life conditions, it could be because of posture, it could be for chemical reactions, it could be because of hormones. So many things can play a role in consistent pain. So we always have to assess our pain, okay? And what is our pain spectrum, okay? Someone could have pain because of syndromes, nerve compressions, cancer, chemical, mechanical pain. I think one of the most important things is to be able to determine, is it a chemical or is it a mechanical pain? And so this is something that you need to monitor all the time, and being able to, what is the pain? You evaluate, and you always need to reevaluate, okay? And again, pain is disproportional to the injury, okay? There is this thing called complex pain syndrome. And people do have disproportionate amount of pain to what is going on. Chronic pain syndrome, okay? Severe pain is probably the biggest one. But again, they could be hypersensitive, joint stiffness, muscle guarding, which is a cascade of events that build over time. So it's very difficult to understand. And it's not always proportional to what we think. So then we have this thing called myofascial pain syndrome, okay? And it's pain from muscle and connective tissue. Usually it's association with parts of the spine, okay? Cervical or lumbar. And it could have myofascial pain anywhere along the body. It's not really well understood, okay? So there are some causes we need to think about. And again, it could be chronic and it could be over a longer period of time. But posture, stress, triggers like that, traumatic injuries, motor vehicle injuries, whiplash, all are components of this, what could be this myofascial pain. And as we continue to study the fascia, we're learning more and more about it. Okay? And again, this chronic pain, okay, there are pain centers that are out there that we need to be aware of. But again, it's that conscious, that continuous amount of pain. And I call this inflammatory soup, right? Low pH, sensitive free nerve endings, trauma. Inflammation itself can just cause pain to a person, whether inactivity, too much activity, okay? And then you also have the mental component of it. So we do need to be considerate of the different sources of pain and where it's coming from, okay? And we're going to look on how we're going to be treating these.